Good afternoon. I'm Dr. Horst, work at the Beth Israel Deaconess Medical Center, and I'm happy to be giving the lecture once again on entitled Cases to Remember. I try and select a few cases that we've seen at our institution that will enlighten us about some of the more interesting elements of gastroenterology, and I hope you'll enjoy these today. I'm going to ask you to participate silently, if you will, because we don't have the face-to-face interchange. I'll give you some opportunity to think about the questions posed, and then I'll try and move on with our own discussion about them. So the first case is entitled Emerging from Confusion. And this is about a 57-year-old gentleman who presented to his primary care doctor with a history of confusion spells over some period of time. They started about 3 years ago, but this year they seem to be getting worse, which prompted his request for help. They usually happen in the afternoon, and he described slurred speech, difficulty balancing, and his wife described him as appearing disoriented. He was awake and able to function. He just wasn't quite normal. His past medical history and surgical history are as listed here: some hyperlipidemia, sleep apnea, prediabetes. He's a carrier of the HFE gene, but not with no manifestation of that. He works in stained glass, and so he is exposed to lead and has had high levels of lead in his blood in the past, which have been treated. His surgical history is unremarkable. He's married, works, as I mentioned, a stained glass conservator, never a smoker, a couple of drinks each week, usually a glass of wine with dinner, and he uses no recreational drugs. So what's our differential diagnosis of confusion spells? Well, it's quite broad. We wonder about hypoglycemia, certainly. That's one of the things we could think about, even having an insulinoma, for example, producing this. Neurologic events such as TIAs or seizures. We wonder about some toxic ingestion or substance abuse or even surreptitious alcohol use, even though he doesn't describe a great deal. And then we wonder about something going on in the brain itself, either a brain lesion or even metabolic problems such as hepatic encephalopathy. Finally, maybe they're just psychogenic episodes of some sort. So with all of this in mind, a workup was initiated. Laboratory tests were basically okay, including toxic search for toxins such as lead, cadmium, arsenic, and mercury. All of them were negative. His labs essentially did not provide a clue here. His brain MRI did not show any lesions, and an EEG show any sign for seizures. So we've come up empty-handed, and came back to his doctor. He's still having these episodes. He just seems intoxicated, as his wife described it. And she pulled up a couple of videos of him having trouble finding words, stumbling, looking confused, very much like he was drunk. His PCP recommended that they get a breathalyzer test to see if, in fact, he has some alcohol responsible for this. And so they got a breathalyzer, and sure enough, he was found to have variably elevated blood alcohol content during the spells, often in the zone considered to cause impairment. So based on this data, a diagnosis was contemplated, and I'll give you just a moment to think what could be going on here. And if you know it, you probably guessed it. And this is an example of auto-brewery syndrome. This is a very rare condition in which the gut ferments the carbohydrate, which is there, and produces alcohol or ethanol. And this then gets into the bloodstream and produces the symptoms as if the patient is drunk. In fact, the patient is drunk, but the alcohol is endogenous rather than exogenous. This is a very rare diagnosis, less than 100 reported cases, but it's probably underdiagnosed. because we don't recognize it, we don't do the test for it. And in fact, we are presenting this because we actually had two cases this year to titillate our um, interest in this subject. So the pathophysiology is basically that so there's some perturbation of the microbiome, which leads to fermenting the carbohydrates in our gut. Maybe antibiotic use that does this. There could be underlying medical conditions, particularly those that might change motility. SIBO is a possibility. Short gut syndrome might be one. And it may be related to dietary factors. The offending microbes, there's quite a list of them. Candida is one, Saccharomyces, which is, of course, the same as brewer's yeast, are in that family. And then the number of bacteria as well, including Klebsiella, Enterococcus, and Citrobacter. As with many of these syndromes that involve gut bacteria, it's very hard to diagnose these definitively because our ability to study gut bacteria and yeast is not very good. This presents it with obvious signs of intoxication after large carbohydrate meals. And sometimes people are arrested for driving under the influence. There are subtler changes as well, such as chronic fatigue, maybe even somebody feeling like they have a hangover all the time. There may be mood changes, irritable bowel syndrome or symptoms, and belching or vomiting. And the question is, when you see somebody with these symptoms, how do we make a diagnosis of Brewer syndrome? And basically, you have to rule out everything else. So you do a complete history and physical. You find the timing of the episodes, maybe associated with the hours after eating, the description of drunk-like behavior. And it's very important to get friends and family to weigh in on this because the patient may not be able to perceive exactly what's happening. Rule out psychiatric diagnoses, rule out secret drinking as much as possible, and eliminate other causes that we have tried here. And then the breathalyzer log may be the most key here to see the elevated blood alcohol content during the episodes. There is a diagnostic test called a carbohydrate challenge in which you observe the patient for 48 hours after making a thorough search to make sure there's no alcohol available to the patient. You give them a 200-gram glucose load and do these serial blood alcohol concentrations up to 24 hours. And the elevated levels in the absence of any exogenous alcohol intake will confirm your diagnosis. Treatment, carbohydrate-free diet. We do antifungal therapy, which may change the source of the alcohol, and sometimes probiotics to rebalance the system, which we use for everything nowadays. There's limited data to guide us. We'll try the empiric antifungals. Sometimes a high protein, low carbohydrate diet can change the substrate available for the organisms. And probiotic supplementations, as we mentioned. Try to avoid antibiotics, which will only perturb the system further. And sometimes we need to get neurology and psychiatry and other disciplines involved to make sure we have the right diagnosis. Nutrition can help. The prognosis is uncertain. Some combination often eliminates the symptoms, but they may come back. And sometimes patients are able to eventually resume a regular diet if you can change the biome appropriately. Some authors about this have recommended doing endoscopy and colonoscopy, collecting contents to try and study the bacteria and organisms. As I mentioned, I think this is difficult to do, and we don't have a good way of doing it in most cases. So I'm not a particular fan of pursuing this. It does raise the question, though, in today's whether perhaps a fecal transplant might ultimately be helpful in this diagnosis. Again, if probiotics and antibiotics are not successful, then changing the biome in this fashion has some potential, but this has not been experimented. Our patient received dietary restriction. It didn't really help. He got Xifaxan, did not help, but finally with fluconazole, he had some improvement. On the left, you'll see some high blood alcohol contents, and on the right, they pretty much disappeared after the fluconazole, and his symptoms actually improved considerably. So I mentioned we had a second case, so let's do another quick round. This is a 54-year-old female with a history of gastric bypass, low thyroid, depression, prior alcohol use, which also makes this diagnosis more complicated. But she came in with persistently high elevated levels of phosphatidylethanol. PTH is like the hemoglobin A1C. It measures the level of alcohol over a period of time and gives you some sense of whether the patient has been drinking, not just at the moment, but over a longer period of time. So this woman actually had antibiotic treatment several years ago, and since then she just doesn't feel right, often feeling dizzy and flushed. She says, I'm not drinking. And in fact, she's being tested regularly through a detoxification program that she participated in. And despite saying she's not been taking alcohol, her urine has alcohol and PETH levels suggesting significant exposure. She opted to undergo the glucose challenge that we spoke about, and indeed, her levels were quite high. She was in house at this time, and the note written by the physician who saw her regarding her altered mental status said that she was arousable but lethargic, slurring her words and asking questions like, "Is this real?" And she was able to tell the physician she'd come to the hospital for a metabolic workup. And although she wasn't endorsing any pain or specific symptoms, when he asked her if she felt drunk, she says, yeah. Vital signs were okay. She appeared okay. And as I mentioned, the blood alcohol levels were quite high. They did a search of her belongings when she came into the hospital, and with her permission, again at this time, and no alcohol was found. So a presumptive diagnosis of autobrewery syndrome was made for this very complex woman. This second case tends to bring out some of the difficulties with autobrewery syndrome. It may interfere with your ability to work. It brings up legal issues around DUI or alcohol abuse. And it certainly can make it challenging to get through relationships and social situations with this problem. So there are other questions that have never been answered because this is so rare. Does this lead to alcohol use disorder? Could you get liver disease from this? And I think as we diagnose this more frequently, we may learn more about it. Case number 2. This is labeled spurting, and you'll see why in a moment. This is a 79-year-old female with an orthotopic liver transplant in 2003 who presents with GI bleeding from a chronic enterocutaneous fistula. Her previous diagnosis of cirrhosis was based on hepatitis C. And after her transplant, she then developed a recurrent hepatitis C, which again led to cirrhosis of the allograft. And she had, in addition, alloimmune hepatitis, which is being treated with azathioprine. This is like autoimmune hepatitis, but in a graft, and it occurs in a very small percentage. So she's got ongoing liver disease. Her fistula was a result of peritonitis in 2009. And the initial transverse colectomy and Hartmann's procedure was complicated by leaks and multiple surgeries. And ultimately, she ended up with an endoleostomy. She also ended up with an enterocutaneous fistula, which could not be fixed surgically. And so it has persisted since then with a clear yellow output each day. Here's a picture of her stoma and of the fistula up in the upper abdomen there. Over the 10 years, she's had recurrent intermittent small volume bleeding from the fistula, which has not been significant enough to be concerned about. But the current episode, which started 2 weeks ago, has progressed to large volume, bright red blood with clots. This has soaked her dressings, it pooled at her waist. It was really quite significant. Of importance, there was no blood coming out of her ostomy. Vital signs unremarkable, general exam, no stigmata of liver disease, despite her long history of this. She has an ileostomy with brown watery output. And in the upper abdominal midline is the fistula tract, and there is oozing of blood from this. Labs showed a drop in hemoglobin from the bleeding. Her chronic renal disease is manifest with a high creatinine. Liver tests are actually pretty good. The CT abdomen and pelvis showed, with oral contrast, showed no evidence of the contrast coming out this enterocutaneous fistula. The exact source of this it was not clear. So what's going on leading to this bleeding from the enterocutaneous fistula? I'll give you a brief moment to think about that. We thought about numerous possibilities, small bowel sources such as an AVM, doulophores, neoplasm, ulceration, a Meckel's conceivably, or ectopic varices since the patient has liver disease history. In an upper GI bleeding that is coming out through the fistula, such as varices, ulcer-disease, neoplasm, and so on, seemed less likely in the context of blood not coming through the stoma. So we thought it must be localized to the fistula. And what would you do next to try and figure this out? We grouped our transplant hepatology group, our surgery, GI radiology to figure out what we might do. And ultimately, of all these potential ways of pursuing this, we chose angiography. And this was done to see if we could spot something on the vein that was bleeding. And in fact, on reviewing the images, there was a suggestion of an endoluminal varix or small bowel venous ectasia on the inside of the fistula. So interventional radiology offered a portal venogram and a potential embolization. And in fact, they were able to mark the fistula site with that little clip there, or metal thing, which is in the red circle. And then they put a wire transhepatically in and injected dye. And it turns out that with a direct portal venogram, the dye was all moving towards the liver and nothing really showed up. But when they occluded the vein, the portal vein, then there was some reversal flow, and it went, in fact, exactly towards that small enterocutaneous fistula. So the next step was to selectively catheterize this area and inject some foam. And in fact, this stopped the blood flow to this area. There's been no bleeding since. The conclusion is that this is an ectopic varix that was localized in the fistula. Ectopic varices, you're all familiar with. They are systemic collateral veins in unusual sites. They're all attempting to carry the portal blood back to the heart around the narrowed high pressure in the liver. They constitute a small percentage of variceal bleeds in patients with intrahepatic hypertension, and about 20 to 30% of those with extrahepatic portal hypertension. They're often very difficult to localize. And here I've pointed out that very commonly would be along the abdominal wall, such as when the umbilical vein comes up and you see the typical caput medusa, which is a form of ectopic varix. But anywhere else where there's been surgery, or there's a chance for the systemic vascular supply to come in contact with the portal supply, there may form varices. And this is most commonly seen in the duodenum, but you can certainly see it in other areas. The rectum, when you see hemorrhoids, you wonder a little about whether they could be ectopic varices in a patient with portal hypertension. And that can be a difficult distinction, but ultimately becomes a statistically important a part of the ectopic variceal program. Peristomal varices are another opportunity for the portal circulation to have contact with the systemic circulation, and that's another source we're all familiar with. If you look back at our patient, in fact, not only is do we have the intracutaneous fistula up here, but around his stoma, there's a bluish discoloration, which is fairly typical of the varices around a stoma that can form. And I think that was a clue to us that the portal hypertension had the potential to be involving the intracutaneous fistula as well. Treatment, endoscopic treatment is usually unsuccessful, such as variceal ligation or injection. Coil ligation is one option, and tips with lowering the pressure is one thing to consider when you're really stuck with portal hypertension causing ongoing bleeding. In our case, we use the balloon-occluded retrograde transvenous obliteration, which proved successful and hopefully will be durable. Take-home points. These can be very small and subtle, making them a challenge to identify and to treat. And oftentimes you need multiple disciplines to put their heads together to figure it out. Case number 3 is what I've titled an interesting twist, and maybe a clue for you here. This is a 54-year-old man presenting to the ED with 48 hours of abdominal pain in the right lower quadrant. Initially, it was diffuse and then localized. No other symptoms along with it. His past medical history is pretty unremarkable. No GI symptoms in his case or in his family history. And he'd had a previous colonoscopy that was normal. On exam, he was mildly uncomfortable. He was tender to palpation in the right lower quadrant, but no peritoneal signs. The labs were unremarkable. And CT revealed this tubular structure in the right lower quadrant near the cecum, but separate from it. The terminal ileum and the cecum were normal. MR confirmed this tubular structure with a little bit of a lumen in it. And what was most interesting about the MR is that right adjacent to it and above it was this kind of world-like appearance here, really right at the base of the cecum. So what the heck is this? In your differential diagnosis, something that's twisted, obviously. And it certainly seems like it ought to be in the area of the appendix. So maybe it's a big, giant, twisted appendix. And in fact, they went in surgically, and you can see at the top here this sort of twisted pedicle here, which was attached to the cecum, and below it this distended, dilated appendix. This was removed. There was no evidence of perforation or spillage of mucin into the cavity. And on pathology, it was filled with mucin and pretty much denuded walls, although in the area where there was some epithelium, there was some mild dysplasia present. The other important thing is that the mucin was invading into the muscularis propria here. And so this was diagnosed as a low-grade appendiceal mucinous neoplasm, or an LAMN, a relatively rare tumor. The staging on this is because it was invading through the muscularis propria is a PT3. And this is important in deciding what the potential malignancy or prognosis would be. And this is not a bad one. Margins were uninvolved. Mucinous neoplasms we're kind of familiar with. We talk about mucoceles, but that's a very generic term, just meaning mucin distended appendix. And when you divide it down, there are cystadenomas where there's proliferation of mucin-containing epithelial cells, but no local invasion or disruption of the lamina propria, as we saw in this case. Then there's the LAMN, where there is some dysplastic epithelial cells, and the mucin will push into the muscularis propria And finally, you can have the most malignant type of mucinous adenocarcinoma. Of course, we're all worried about spreading mucin with these malignant or cells into the peritoneal cavity. And if that happens and they take up housekeeping there, you may end up down the line with the pseudomyxoma peritonei complication. So that's why the surgeon has to be very careful about removing this without allowing any leakage. Management generally is surgical. The risk of nodal spread is quite low, and so appendectomy is usually the definitive cure for this. And if there's any invasion beyond the appendix, a right hemicolectomy is done and hope that there have been no spillage and potential for metastases there. The twist on this was quite unusual. It's a rarity that may be discovered intraoperatively and increases the risk of spillage, so you have to be very careful about that. Overall, it's tumor stage that predicts its prognosis, and in this case, it was a relatively low one. And as I mentioned, appendectomy is usually the definitive treatment. Time for one more case here, which I've titled "This One is Going Viral." This is a 65-year-old woman with generally good health, no GI symptoms, came for a routine colonoscopy, and her previous colonoscopies had shown some adenomas. The following lesion is seen during a retroflexion, and you can see there is a kind of an irregularity right at the dentate line and perhaps just in the anal canal. And in the lower right-hand picture, there's a little, you can see this is a kind of a nodular quality here with a little central indentation. The endoscopies felt that it was overlying the hemorrhoids, felt very uncomfortable removing it, but he took biopsies. Oh, sorry, took biopsies, and just give you a thought. Would you have taken this off with a snare, or were the hemorrhoids, scaring you off as this particular gastroenterologist? He felt that the lesion was probably intraanal and therefore was more likely to be a squamous cell lesion. It also was overlying the hemorrhoid. And so for both reasons, it decided just to biopsy it. And the biopsy came back showing a tubular adenoma with no dysplasia of any sort, but just a standard adenoma as the patient had before. At this point, the gastroenterologist had referred the patient to an anorectal surgeon who is used to dealing with squamous lesions and anal canal lesions. And she looked at this and, in fact, went in and described that the lesion was at the dentate line, overlying hemorrhoids, about 11 millimeters in size, with the depressed center that we saw. It was not adherent. She decided, because of the hemorrhoid, that she would not use her usual laser technique for removing anal lesions and then put a ligature around it and remove the thing intact, and then tied the varix, the hemorrhoid as well. And it came back, to her surprise, with a small focus of intramucosal adenocarcinoma within the adenomatous epithelium that had some low and high-grade dysplasia, all of those missed by the simple biopsy taken by the gastroenterologist. There was no definitive invasion of this carcinoma. Since she is used to dealing with anal lesions, she sent this off to neogenomics, where they do special stains for HPV. And to her surprise, this came back with HPV subsets 16 and 18, which are the highest risk ones, in this lesion, and specifically in the adenocarcinoma cells. The final path note, therefore, included this, that they were positive for HPV 16 and 18, consistent with this being an HPV-related intramucosal adenocarcinoma. Well, this is kind of interesting and a little surprising. Um, as we know, HPV infection is the most important factor in the development of cervical cancer and in squamous cell cancers in the anus or in the oropharynx. They've defined many different subtypes of HPV, and 16 and 18, and about a dozen others, are most commonly associated with the development of malignancy, 16 and 18 in particular. And so that is why those are the staining has been developed to find these, and identifying that may help identify those who are at the greatest risk of cancer development and may affect your screening protocol. How often do we see HPV in the anal canal? Well, one study showed in women, about 27% would have this, and usually coincident with them finding it on the cervix as well. In another study looking at men, it was about 16% of heterosexual men have HPV, and about a third of those actually had this high-level oncogenic type of subvirus. Now, what about HPV and adenocarcinoma? Well, in the cervix, it's usually in squamous cells, and so you get a squamous cell carcinoma. But when it does infect the glandular cells, occasionally get an adenocarcinoma, and they do see HPV associated with it. But it's a little bit unclear in the literature whether the HPV and adenocarcinoma is truly a causative relationship. In the anal canal, adenocarcinoma is quite rare, less than 1% of all neoplastic lesions. But there are reports of HPV associated with adenocarcinoma, as we saw in this case. In the colon, there's no association of HPV with any of the adenocarcinomas that have been identified. Now, primary adenocarcinoma of the anal canal is rare. It can be hard to distinguish from a low-lying rectal adenocarcinoma, right at the dentate line. And HPV may well be a factor in the development of this lesion, as we think may be the case here. Anal adenocarcinoma has a worse prognosis than the more common squamous cell carcinoma, which is usually treated with radiation, as you know. And so the algorithms are usually include a more aggressive multidisciplinary approach to its treatment. Well, that's it for the time. I'll remind you we've gone over autobrewery syndrome, ectopic varices, and a fistula, the low-grade appendiceal mucinous neoplasm, and in this case with this unusual presentation of torsion of the appendix. And finally, an anal adenocarcinoma-related HPV. And in fact, this picture here is the HPV virus to send you home with good memories of hopefully an interesting lecture. Thank you very much for your participation.